you for the introduction. I'm just going to hopefully successfully share my screen. Okay, so hopefully everyone can see that. Jeavana, can you give me a thumbs up? Is it good? Okay, okay. Okay, great. Let me just move some of these things. So thank you very much again for the opportunity to present to you today. We're hoping to present a little bit about what we're learning from our research on who in the workforce, at least in Ontario, may be most at risk of opioid-related harms. And I'm not sure about the background, of people here, but the opioid crisis has really had a devastating impact on so many Canadians, including working Canadians. And so it's really important to think about whether the workplace has a role to play, either as a potential contributor to the harms that we've been seeing, but also hopefully in the solutions to mitigating these risks. So the research that we're going to be presenting today is the result of a collaboration between the Institute for Work and Health and the Occupational Cancer Research Centre at Ontario Health, both of which are based in Toronto. And this research was made possible with funding from the Public Health Agency of Canada. And in addition, the Occupational Disease Surveillance System, which lies at the heart of this project, was established with the support of the Ontario Workplace Safety and Insurance Board, the Ministry of Labour, Immigration Training and Skills Development, as well as the Ministry of Health. I'd also just like to acknowledge that we have a project advisory committee that has been providing guidance to us throughout this project. So the committee includes labor and workplace representatives, individuals from health and safety associations here in Ontario, public health and substance use experts, as well as representatives from the Ontario Workplace Safety and Insurance Board and the Ontario Ministry of Labour, Immigration Training and Skills Development. So the first couple of polling questions are really meant to just get a sense of how much people know about the opioid crisis at the population level. So between January and June of 2023, on average, how many opioid toxicity deaths took place daily in Canada? So we'll just give you a few seconds to answer. Okay, so I'm hoping that the results are being shared right now. So it looks like people seem to be mostly split. So about a third have said 22 deaths on average per day. Another third have said 16. And then we had a few also, about a fifth, who said 8 or 12. And so the answer here is actually 22. So, very trying. Yeah, so there have been 22 opioid-related deaths taking place daily in Canada, according to the most recent data from Public Health Agency of Canada. And that's essentially amounts to over 40,000 opioid-related deaths that have occurred among Canadians over that short time period. We have one more polling question. So here, when thinking about age and sex as a key demographic, what demographic do you think has been most impacted by opioid-related harms? Okay, great. So it looks like the majority of people have said males of working age, and in fact, that is true. So when we look at the breakdown of deaths by age and sex, which is the graph on the right-hand side, what we do see, so this graph is for 2022, but we see this pattern essentially from year to year, that males of working age, particularly those between the ages of 30 to 49, have been disproportionately affected. And given these demographics, there has been greater interest in understanding whether occupation and the workplace environment have a role to play and why we're seeing these patterns. So from a research perspective, most of what is actually known about the role of occupation in opioid-related harms has come from studies in the US, several of which have demonstrated occupational patterns in opioid-related deaths. And across these studies, opioid-related poisoning deaths have been particularly prominent among those in construction and trades, natural resources, transportation, maintenance, healthcare, and services. And across these, you can sort of start to see a bit of a common theme. Many of them are typically what we would consider physically demanding jobs. In Canada, on the other hand, we know relatively little about how this crisis has affected the working population. So here in Ontario, we have some data that I think the most recent has come from March to December 2019 and March to December 2020 from records of coroner investigations. And in this particular analysis, what they found is that 13 to 16% of those who died were known to be employed at the time of death. And it's certainly not a trivial proportion, but I think what's important here to also highlight is that among all opioid-related deaths that were investigated by the coroner here in Ontario, about a third had an unknown employment status, for which we have no information on history of employment and occupation. So we already are starting to see some of the data gaps. When we look at that group of about 13 to 16% that were known to be employed at the time of death, we see that most were employed in the construction industry. And this is consistent both pre and post-pandemic, fairly consistent with also what we see in the US studies. But again, it's important to highlight those data gaps. So even among those for whom we know were employed when they died, about 16% were missing occupation information. So our project team's been trying to fill some of the knowledge gaps that we have on this issue here in Ontario by adapting an existing resource known as the Occupational Disease Surveillance System. So the goals for today's presentation will be to present some of the findings from our analyses. In the first set, we've compared rates of opioid-related harms among formerly injured workers in the ODSS to those in the general Ontario population. And in the second set of analyses, we've been examining whether there are occupational patterns in opioid-related harms among these workers. Just very briefly, at the end of the presentation, I'm also going to be introducing you to the Opioids in Work data tool that we just released in December. I'm just going to turn it over now to Jeavana, who's going to take you through the methods and the results.
Thanks, Nancy. Great. So at the Occupational Cancer Research Center, we established a unique system known as the Occupational Disease Surveillance System. So we often refer to this as the ODSS or the large cohort, which we use to identify and monitor trends in work-related disease in Ontario. So this system was originally created in 2016 by linking existing provincial health databases with job information in order to study occupational disease and ultimately inform prevention activities. So the ODSS is useful because it identifies at-risk workers, potential hazardous exposures within the workplace. And so far, it's been successful in identifying many cancers and non-malignant diseases. The system contains information on approximately 2.37 million Ontario workers. For this project, we're using approximately 1.7 million, and I'll explain the methods in the next few slides. And I just want to add that the development of the ODSS was possible because of funding from the Ontario ministries. So for this project, the ODSS or large cohort includes occupational data on about 1.7 million Ontario workers. And so workers are first identified in the Workplace Safety and Insurance Board, WSIB, accepted lost time compensation claims records from 1983 to 2019. And the WSIB file contains information on accepted lost time claims for a work-related injury or illness for workers in the province of Ontario. So this is where we identify the workers' employment information through their reported occupation or industry. And occupation and industry are reported in 3 distinct levels. So many of you may be familiar, we refer to this as division, major and minor levels, where division is the broadest grouping and minor is the most specific. So because workers enter the cohort due to an accepted claim, we often refer to them as formerly injured workers, and these are the individuals who make up the ODSS cohort. So these formerly injured workers are then linked to the registered persons database. So this gives us information on if an individual died or emigrated out of the province, along with their residential information. So it's also called the RPDB, and this includes all Ontarians who are registered for provincial health insurance. So each person is assigned a unique health insurance number. We can use this health insurance number to link the workers to hospital records. So we link them to the discharge abstract database and the National Ambulatory Care Reporting System so that we could identify opioid-related hospitalizations and emergency department visits. And they have to have occurred between 2006 and 2020 because that's what we have available with reporting. And so workers are followed until they are hospitalized or they visit the ER for an opioid-related harm. And we're following them until the diagnosis of their opioid-related outcome of interest, age 65, so that we can cap it to the working age group, death, emigration from Ontario, or the end of the follow-up period, which is December 31st, 2020. So now that we've identified sort of our cohort, here we're presenting two types of opioid-related harms that we can identify in the hospitalization and emergency department visit between 2006 and 2020. So the first is opioid-related poisonings, which many of you refer to as overdoses. So poisoning can occur when an opioid is taken incorrectly and results in harm. Poisonings can be differentiated by intent. So we can look at if they were accidental, intentional, or of unknown intent. And poisonings can involve pharmaceutical opioids, non-pharmaceutical opioids, or a combination of both. The second harm that we're going to talk about today is mental and behavioral disorders. So this includes a wide variety of mental and behavioral disorders that can differ in severity or clinical form. So examples are withdrawal or intoxication, but they're all attributable to the use of opioids and may or may not have been medically prescribed. So overall, in our ODSS, we've identified through hospitalization and emergency department visits, we've identified about 10,000 cases of poisonings and about 11,000 cases of mental and behavioral disorders. So I'm going to present two different analyses in this talk. The first analysis is comparing the risk of opioid-related harms among workers in the ODSS to the general population of Ontario. So we're going to compare our group of 1.7 million workers to the general Ontario population to understand how the risk of opioid-related harms compares. So the next slide just gives you an idea, again, of the comparison group. So comparing the rates of opioid-related harms among the workers in our large surveillance system to the general Ontario population. So when we compare the ODSS cohort of workers to the general Ontario population, we saw elevated risks of all opioid-related harms among these workers. So I'll briefly explain what this means. So we use the standard incidence ratio as a risk estimate, and an SIR greater than 1 means that the risk of opioid-related harms is elevated among workers in the ODSS. And those for those who are familiar with risk estimates, these are all statistically significant. So when we look at the data and the overall risk by type of harm, so poisonings or mental and behavioral disorders, we see that these are elevated among the workers in our cohort. If we look at this by data source, so emergency department visit or hospitalization data, we still see an elevated risk across the ODSS workers. And so here you can see the overall results. So it might be hard to see this graph, but what we're showing you is really the results by occupation at the division level, separately for emergency department visits and for hospitalizations specific to poisonings. So the overall SIR is shown at the bottom, and you can see that many of the groups are elevated or beyond the overall average risk. So based on this, we know it's clear that many of these groups are at an elevated risk, specifically those where we expect to see elevated risks, such as construction workers, where we've seen a lot of the reporting previously on construction workers in Ontario. But then we're also able to identify some of the groups that have not really been identified in the existing literature. And we see this consistently when we're looking at the different data sources. So whether we look at emergency department visits or hospitalization data, we still see an elevated risk across similar groups. And the next slide shows you similar patterns when we look at mental and behavioral disorders. So again, by emergency department visits and hospitalizations, again, you can see the overall SIR shown at the bottom, and you can see that many of the groups are elevated beyond the average overall risk. So again, we see the same groups: construction trades, material handlings related, processing, so the various processing groups. And we will talk a bit more about these groups in the internal analysis. But right now, this is to give you an idea of what we're seeing when we look at sort of the broader occupational groups in the ODSS. So the second analysis is the one that we're going to spend a little bit more time on. And it's really where we're examining the occupational patterns of opioid-related harms among workers within the ODSS compared to other workers who are also in the ODSS. So for example, we want to look at construction workers, and we want to compare their risk to other workers in the ODSS rather than the general Ontario population. And this actually gives us a comparable group because we know that everybody in the cohort was a formerly injured worker. So when we look at the groups at the division level, so again, the broadest grouping of occupations, we can see that there's significant elevated risks of both poisonings and mental and behavioral disorders across these groups in construction and trades, forestry and logging, material handling, processing, so both are processing groups, and machining. But the interesting thing is, given that we've got such a large cohort, we've got these broader level groupings, we actually do have the ability to dig deeper to see what are the specific groups that are making up sort of the higher risk groups versus those that have no association or lower risk. And this is what we really want to do with the data, is understand where these patterns are emerging from. So who is it in construction and trades that we see an elevated risk for? You can also see that the findings are similar to when we compared them to the general Ontario population. So on the next slide, we also wanted to share some of our division level occupation groups where we see mixed findings. So we may only see an increased risk in mental and behavioral disorders among mining and quarrying workers, but then we see poisonings as an elevated risk for poisonings among transport equipment operating workers. And so we're able to get into the data to understand, are the patterns similar across each of the different opioid-related harms that we're looking at, or even just by data source. So to go a little bit deeper into the data, the next few slides show sort of the major level grouping. So this is our intermediate level of coding that we have available for the occupation groups. So we're able to dig down from our broad construction and trades groups, and we're able to look at the three major groups here, which is excavating, grading, paving, and related, electrical, power, and related, and other construction trades. And what we see is that there's an elevated risk for excavating, grading, paving, and related, and for other construction trades, which often includes workers such as carpenters, roofers, and bricklayers. But we see a significantly reduced risk among those employed in electrical power, lighting, wire communications, etc. So this is important for us to understand sort of what the direction of the risk looks like among these smaller groups within construction and trades, so we can pinpoint where these prevention activities can focus. So similarly, when we're looking at machining, and just for those who may not be familiar with the risk estimates, they're provided within each bar and statistically significant. So when we're looking at machining, at the division level, we saw an elevated risk. And when we look at the major level groupings, we can see that this is primarily driven by those employed in metal shaping and forming, which includes welders, boilermakers, sheet metal workers, and at the major level, when we're looking at metal machining occupations, this includes tool and die and machine setting up occupations. And we can see that those actually have a reduced risk. And so it's important for us to understand which groups are sort of driving our increased risk, but also the groups where we may not see an elevated risk or no association or reduced risk. And on the next slide, again, we can dig a little bit deeper into the transport equipment operating group. So here you can see that the risks are elevated among water transport and motor transport occupations, but reduced among air transport occupations. And no relationship when we look at the railway and other transport workers. And so this again tells us who in the transport equipment operating group has an elevated risk compared to everybody else in the ODSS cohort. So those are examples of the major level findings that we see. Another interesting thing is, although we shared sort of the consistent findings that we see throughout our analyses, we also wanted to share groups where there's mixed findings, where, in other words, inconsistent findings. And so this is, again, specific to when we compare workers to all other workers in the cohort. And what we saw was we didn't see an elevated risk at the division level for these groups, so medicine and health, service, sales, and clerical work. But when we can dig a little bit deeper and further into the data, we do see elevated risks among specific major and minor groups, such as nursing aides and orderlies. And another interesting group is sort of our service workers, which we know is a mixed bag of occupations, but we see elevated risks among janitorial cleaning staff, food preparation workers, lodging and other accommodation workers, personal services, so this includes hairdressers and barbers, and other apparel services. We also see some of these findings across sales and clerical work. So it's interesting to compare the findings across each of the analyses to understand sort of what's driving the risk across these groups. But we don't really have a clear idea, given that we're able to dig down deeper, but we don't have, some of these groups don't have existing evidence in the literature that would help with understanding why we're seeing these findings. So I'm going to actually pass it back to Nancy, who's going to take us through sort of the key messages and how we're going to interpret the findings.
Thanks, Jeavana. So I guess before we continue, Jeavana's highlighted some of the occupational groups that seem to be at higher risk. Before I summarize the results and get into that, I sort of want to just get a sense from you on what you think may be contributing factors. So here, there's a number of options that are listed. I believe you'll be able to select more than one option here, so this isn't just one. So we'll just give you a few minutes to see. Okay, so it looks like, so people have selected a bunch of different options here. It looks like the main ones are the psychosocial work environment factors and physical work environment factors and injuries. To a lesser extent, issues around job precarity, work arrangements, and norms and stigma in the workplace. So what I will say, so I'm going to get into a little bit of that. What I will say is that we don't really have a lot of evidence to be able to support any one of these, but all of these have been hypothesized in some way as being a contributing factor. So I'm just going to quickly take a step back a bit. If you recall, the group of workers that we were examining in this study that are in the ODSS, they all previously had an accepted lost time workers' compensation claim for a work-related injury or illness. And when we compared this group of formerly injured workers to the general Ontario population, working age population, we found that the rates of our two key opioid-related harms were significantly higher. These results lend support to a potential role for work-related injuries as a contributor to opioid-related harms. And I will talk a little bit more about that in a moment. With that said, there is an important caveat. So at the moment, in the ODSS, we lack data on opioid use. So what that means is that we don't know the source of opioids that led to the harm. We don't know why they were being used, whether they were being used for the injury or for other reasons. And we don't know when workers began using them. So we cannot necessarily attribute the opioid harms that were occurring among this cohort of workers to opioids that were prescribed for the work injury that got them into the cohort. I think the other sort of key finding here is that we can certainly see that certain occupational groups seem to be at higher risk of having one of these opioid-related harms. And this was particularly true for occupations that we traditionally consider physically demanding. So these results are consistent with those studies that I mentioned at the beginning from the US. And while we don't know exactly why this is all happening, it does provide a signal for which subgroups of the workforce may be at higher risk and where we may want to start to strategically target prevention and harm reduction activities. So I mentioned the one important caveat here that we don't have data on opioid use, but there are some other limitations that I just wanted to mention about our analysis. So we were only able to adjust for a very small number of characteristics in our analyses, so namely age, sex, and region. So it is possible that unmeasured differences in the groups that we compared could explain some of the results, particularly when we compared workers in the ODSS to the general population. The other thing is that when in that comparison to the general population, we lacked information on employment status for those that were in the general population. So we did limit our analyses to individuals of working age, but it is likely that a proportion of our comparison in the general population was actually unemployed, which in and of itself is a risk factor for substance use. Given that this is also a cohort of formerly injured workers, we don't have data on harms that occurred among workers who did not have an injury claim, nor those that were not covered by the WSIB. And finally, the data on occupation that we obtained was obtained at the time of the workers' compensation claim that got them into the cohort. So some misclassification is possible if workers change jobs. Although we have examined workers in the ODSS who have multiple claims, and generally we have found that there's been good consistency over time in their occupational groups. So I already mentioned the potential role of work-related injuries as a risk factor for opioid-related harms. And there's many reasons why this might be plausible. So we know that work-related injuries frequently result in pain and functional interference that can make it more likely that they'll use opioids to try and alleviate those symptoms, and particularly if they lack access to other pain management strategies. We also have to think about how poor mental health that can often occur after an injury and the potential challenges of returning to work and staying at work, how that can make it also more likely that a worker may use opioids. When we think about those challenges, thinking about things like pressures to return after injury, if they don't have appropriate workplace accommodations that might force them to work through pain, they may have insufficient sick leave, or maybe their job is precarious. And then thinking about things like interruptions in employment, starts and stops, returning, coming off of work, going back, which can exacerbate poor mental health. And so all of these things, sort of a perfect storm to sort of lead to potential issues with using opioids after injury. So in fact, there is, of all of the sort of hypothesized reasons for seeing these occupational patterns in the literature, there is some literature now starting to provide an evidence for the role of work-related injuries as a risk factor for opioid-related harms. So in one study, they found that 57% of those who died of an opioid poisoning had a lifetime history of work injury. In another study, injured workers with low back pain workers' compensation claims had a 62% increase in the risk of dying from a poisoning compared to the general population. And finally, in this last study, injured workers had a 79% increased risk of being diagnosed with opioid abuse, dependence, adverse effects, or poisoning compared to non-injured workers within the first 36 months of injury. So we did that poll. So there are beyond the role for workplace injuries, there are potential other hypothesized reasons from a workplace perspective, at least, for why we are seeing some of the patterns among these occupational groups. So when we think about some of those occupational groups that are sort of at the top of the list, they are typically male dominated. And what that can mean is that certain gendered norms in the workplace about showing strength, about working through pain, not demonstrating any aspect of weakness, could be contributing to the sort of this chronic use of opioids after after injury or with pain. Some industries and workplaces may also be more normative when it comes to substance use in their workplace, or there's other aspects of the work environment that we can think of that could be contributing. So we can think about things like the psychological and time demands of these jobs, how much control workers have over their work, how isolated the work is. So when we think about some jobs where they have to, go off to camps, or they have to be away from their families for a long time, that can be very isolating. We can also just think about the nature of the employment arrangements, so non-standard work as well. And finally, we need to consider also whether concerns about disclosure may be playing a role. So workers may not be forthcoming, not only about any issues that they may be having with substance use, but also about pain, due to concerns about stigma, again, going back to that sort of male-dominated industry piece, but also about the consequences they may face at work if they do disclose that information. And we can sort of think about that a lot with those sort of safety-sensitive environments, where if they have an issue with substances, they may not want to be forthcoming about that, because that could mean that they'll lose their job. And so all of this can really sort of drive things underground and exacerbate issues that the worker is facing. So the results that we've presented today are currently going through peer review at the moment, but they will be made available on a project website that we have, and I'm going to give you the URL in a moment. But in the meantime, I just really wanted to briefly make mention of a data visualization tool that we recently released based on the data from this project. So the goal in producing this tool was really just to allow members of the public, so particularly individuals and organizations looking for data on opioid-related harms from an occupational context, to be able to use the data from our study to better understand patterns of opioid-related harms among this group of workers and understand the characteristics of those workers experiencing harms. And so the tool allows you to create graphs depicting opioid-related hospitalizations and emergency department visits that have occurred among workers in the ODSS from 2006 and to 2022. We've recently updated the data through to 2022. And there's 3 dashboards, one for each of the opioid-related harms that we've already spoken about today, so poisonings and mental behavioral disorders, as well as adverse drug reactions. And adverse drug reactions is a little bit different in that it's when you use an opioid as prescribed, but you simply are having a reaction to it. So it is a little bit different than the other 2 harms that we spoke about today. Within each of the dashboards, there are a series of tabs that will allow you to create custom graphs according to year, age, sex, region in Ontario, including down to the public health unit. And the most unique feature of all the surveillance aspects of in this space is the occupation and industry information that we have. So I mentioned we have a project website, and the URL is opioidsandwork.ca. So once our findings are published, I mentioned they're going through peer review. They will be posted on this site under research findings. So you could find that here. But the tool is already available, and you can access it either along the top buttons, or simply on the front page of the site. We have that front and center. So I would encourage everyone to go and take a look. And you can also sign up for notifications on our site when new findings become available. So thank you very much for the opportunity again to speak today, and we would be happy to take questions.